So as I mentioned before, there are a number of different flavors of CHF. It's not one disease entity. It's a continuum of things. It's a lot of different presentations. It's probably more of a syndrome than anything else. So when we say heart failure, not all heart failure is the same. It doesn't all present the same. It doesn't have the same clinical picture. And if you treat one kind the same way that you would treat every other kind, there's not a straightforward like you do this in every heart failure patient, probably. There's a lot of different flavors of it. And one thing that's good for one person may not be good for another person. So there are many different phenotypes of heart failure, and we'll hit about the top 6 here and what you might do with them in the EMS setting. So I have spelled all that out on this one slide. Now this is a busy slide, obviously, but it does give us pretty much everything that we need to know about heart failure in terms of, again, the EMS treatment of it. And what are the different phenotypes? Well, we can basically break them down. We can start by blood pressure and say either they're hypertensive, we can have normotensive, or hypotensive, i.e. the shock folks. Then there's the phenotype that's CHF with any of the above blood pressures and acute coronary syndrome. So a little bit different than just a little troponin leak or maybe a little non-specific EKG change, but actual acute coronary syndrome going on with it. And then the next phenotype is RV failure, which is a little bit different. All this is mostly talked about like kind of left-sided heart failure. RV failure is a little bit different, and so it gets lumped into its own category. So there's the 5 basic phenotypes of stuff that we'll talk about. Again, what is the primary symptom for any of this stuff? It's going to be, that we're getting concerned about, it's going to be dyspnea, or again, shock. But dyspnea is the primary thing. So you might say, though, wait. Now, as an EMS provider, I see a lot of people with heart failure. I see a decent number of people with COPD as well. And I think it's hard to tell which one is which. But I have heard that if I give somebody an albuterol inhaler or give somebody an MDI or a albuterol neb in the field when they actually have heart failure, that I can make the heart failure a lot worse and don't have to be really careful about that because cardiac wheeze, the folks with CHF can present with wheezing. And so what do I do with those folks? Well, the good news is that you can basically treat these guys in the way that you think is most appropriate. So if you think they have a COPD exacerbation, you should treat them primarily as a COPD exacerbation. COPD, by the way, is not probably going to have the big adrenergic stuff that we get, so like really tachycardic, really hypertensive, that sort of stuff. That's probably going to be more a heart failure picture. But if you don't really know, then it is generally safe to treat COPD as heart failure for at least the basic stuff if in the appropriate setting, and it's generally safe to treat heart failure as COPD until you get it kind of sorted out. Now, what am I saying here? Basically, if you think somebody has CHF and they actually have a COPD exacerbation, the stuff that we would give to them within reason is pretty safe. So is it safe to give nitroglycerin to a COPD patient? Yeah, probably, if indicated in what I'll tell you here. Is it safe to put them on CPAP? Yes, absolutely. Is it safe to put a patient with unrecognized CHF on CPAP even, or is it safe to put somebody with unrecognized COPD or asthma on CPAP? Yes, both are the same. The only time when you really might run into problems, it's not with albuterol or giving them steroids or nitro or CPAP or anything. It's a bit with the diuretics, which I'll talk about why we really shouldn't probably lean on those anyway in most cases, because you could potentially over-diurese somebody who doesn't need it to start with COPD. Or IV fluid, which if you administer to the CHF patient could potentially make them worse if they're already volume overloaded. So if you stay away from the fluid balance stuff, i.e. the diuretics and the IV fluid, if you're not sure, then it is generally safe to give COPD treatments to somebody with CHF and CHF treatments to somebody with COPD within reason if it's unclear exactly which is the problem. In the end, the best I can give you is pick which one you think is most likely and then treat that. And do it within reason, and if it doesn't work, then maybe switch over to the CHF route if you were going with COPD, and likewise switch over to the COPD route if you were on CHF and it doesn't seem like they're getting any better. It's best probably if we just sort of try to aggressively treat them. The number one thing you can do for pretty much everybody, though, CPAP is pretty safe for everyone. All right, so let's look at the first phenotype that we want to look at. These folks have high blood pressure and pulmonary edema. Now we see lots of folks with blood pressure greater than 140. We're really more talking about the folks that are like 160, 180, 222 that have pulmonary edema. That's the first group that we'll look at. And again, we'll classify most of these things based on what their blood pressure is, at least for the EMS evaluation and treatment and the emergency department evaluation and treatment of these folks. So the first group, those that have high blood pressure, greater than 140. These folks will often have pulmonary edema with it and present acutely dyspneic. Now, what could be going on here? Well, these folks usually have a long-standing history of some sort of heart disease, but maybe it hasn't been diagnosed as official CHF yet. They have stiff ventricles and high filling pressures, and when you change the vascular resistance for whatever reason, either they have exacerbation of their hypertension, or they took a bunch of cocaine or meth, or they have pheochromocytoma, or they have thyroid disease, for whatever reason, when you increase the afterload on these folks, their blood pressure goes up a lot, fluid backs up because it can't really effectively pump out of the left side of the heart, it backs up, and where does it back up into? The pulmonary circulation, and so you get pulmonary edema. So these folks will present with a high blood pressure and pulmonary edema. Now, if you let that sit for long enough, it will eventually back up onto the right side of the heart and then back out and give you some peripheral edema as well, but you don't see that real often with these folks specifically because it usually happens pretty quick over the course of a couple of hours. This isn't somebody that says I'm progressively short of breath over the last 2 weeks or something like that. Typically, again, patients don't always read the book, but that's a sort of prototypical presentation I'll give you. They're again hypertensive, and we may look for blood pressures 180, 200, 220, something like that. Over 100 to 120. What are we going to do for treatment for these folks? Well, we're going to, again, decrease their symptoms. The way that we do that is by decreasing their pulmonary edema and decreasing the afterload, which was the big problem with these guys, if you remember the drawing just a second ago. So how do we decrease pulmonary edema and treat their dyspnea? We're going to put them on positive pressure, either CPAP or BiPAP, whatever you have available. And then what we're going to do about their afterload? We're going to give them nitroglycerin. Now, when we do these guys are again pretty hypertensive, 180, 200, something like that. You might just be tempted to call them a hypertensive emergency. But you could kind of get away with doing that by treating them the same way. How would we do that? We'd treat them with nitro, which will lower your blood pressure somewhat. But it's probably not just one sublingual tab. It's probably 2 or 3 or 4 or 5 or even 6 sublingual tabs, all administered at the same time. Now, this is pretty safe, generally speaking, because, again, they're hypertensive to start with. Their blood pressure is super high. So we can give them nitro without having to worry about really dropping it. And how would I do that? You're going to put the CPAP mask on the person. What I would probably recommend is that if their blood pressure is 200 over 120, we're pretty confident that they're going to tolerate the bit of nitro that we're going to give them. So don't do with just one tab. Put 3 in your hand, pop it in their mouth, and then put the CPAP mask on over top of that. Now, yes, you can actually, besides it being a bit of a pain, you can remove the CPAP mask without really untoward effects. If you just, I break the seal and then the CPAP's not going to work anymore. Well, it's not like it's not going to work again in a couple of seconds once the patient is kind of re-equilibrated to having the mask on their face. You can add more nitro after that. But what I'm getting at here is that we want to go heavy on the nitro at this point because if you remember from last talk, it probably takes doses of 250 mics or more before you start getting actual afterload reduction, which you're going to achieve with like 6 nitro tabs essentially. So you could put them on a big hefty drip or give them a bunch of nitro tabs all at the same time. And these people will tolerate it. There are actually studies where people have given doses of 1 milligram or 2 milligrams of nitroglycerin IV push over the course of 30 seconds to a minute, and the patients actually do real well. So we should go really heavy on nitroglycerin in these super hypertensive patients while we're applying the CPAP, BiPAP, whatever you have available as well. And these folks will get better pretty quick. They got sick kind of quick, they'll actually get better pretty quick. And by the time you get them to the hospital with this stuff on board, they may be feeling pretty good at that point. So those are the folks that are hypertensive, and again, this usually happens fast, and they usually present with pulmonary edema without a lot of peripheral edema. How about the folks that are now normotensive? So systolic, under 140, but that's probably actually under probably 150, 160, because most of our patients are a little hypertensive to start off with. Folks that don't have a markedly elevated blood pressure, but are still dyspneic and have a heart failure exacerbation. These guys are the ones that will typically have not only pulmonary edema, but also pretty significant peripheral edema. This usually comes on over the course of a week or something like that, a week or two, where they say, I'm more short of breath, I'm more swollen up all over the place, and I just don't feel good. What happens here? So these guys get engorgement because, again, they've had kind of a long-standing problem. Big stiff left ventricle. They, over time, develop back up into their pulmonary vasculature, which causes the peripheral edema just as before. But they also will develop backflow problems all the way. When you affect the left side, you can only affect the left side for so long before you start backing up onto the right side. When you back up onto the right side, these guys do back up into the periphery, and they get peripheral edema with it. So you have kind of a stiff left ventricle, which doesn't let the left side of the heart pump effectively or accept blood from the pulmonary circulation effectively. That backs up into the lungs, fluid leaks out into the lungs, that backs up further into the right side, which then backs up into the periphery, and so you get the peripheral edema. So this is the classic Michelin man that you would normally see that's gotten swollen over the course of a week or two. Can't lay flat anymore, can't walk more than a couple of steps now when he calls EMS. How are we going to treat these guys? Well, number one, we're going to treat the pulmonary edema again. We're going to address preload and afterload until the patient feels better or until their blood pressure gets low. And then these might be the only folks that may benefit from some diuretics in the field if they are truly hypervolemic. However, it's worth noting, of course, that the effects are not going to be there for 30, 60, 90 minutes, 120 minutes, something like that. So do we really need to give it in the field when we're really not 100% sure on these folks? I still lean on the side of maybe not. But these are the folks where it might be an issue. So again, how are we going to treat the pulmonary edema? With positive pressure, CPAP or BiPAP, whatever you have available, stick it on the person, and they will usually start to feel better within a few seconds if you can get them to relax enough to do it. That should be pretty beneficial and pretty much something that we should address for everybody. What are we going to do with their blood pressure and their preload and their afterload? Remember, these folks are not super hypertensive, so we're going to be a little bit more cautious with the nitro, but we're still going to be aggressive. So give them one sublingual nitro tab at a time until they either feel better or until you get their systolic blood pressure down to 100 or so. Again, that's not going to be that big a drop for these guys. They're not really hypertensive. You don't have to worry about them stroking out. We're going to give them one tablet at a time. And again, you can lift the CPAP mask off in order to pop that underneath their tongue. Do that every 5 minutes until their blood pressure gets low. And what that will actually do at these doses is more affect the preload than afterload. But because you are actually pumping less blood out of your heart and into the pulmonary vasculature that's a little bit overloaded, you decrease the amount of resistance going through there, and you decrease the amount of pulmonary edema. Again, with these guys, these are folks that you might get better by the time you get to the hospital, depending on the length of your transport time. So normotensive, we're going to treat their pulmonary edema with CPAP. We are going to, if appropriate, we're going to move into giving them some nitroglycerin until they either feel better or until their blood pressure is at 100, and then we'll kind of hold there. And these might be the folks that might benefit from diuretics, but I still lean to you can really hurt people. We're still not 100% sure what's going on. It's not going to help you between now and the hospital, so don't worry about that right now. We'll take care of it in the ER if appropriate. All right, that was part one, the hypertensive folks. Part two, the normotensive folks. It only makes sense that we're sliding down into the realm of hypotension. So folks that are low blood pressure and hypoperfused. These folks are cardiogenic shock. If you were writing a simulation scenario, you would call them cardiogenic shock. The primary thing you see with these folks is maybe not so much a dyspnea, but a general shock state. So they may be cyanotic, they're probably going to be cool and clammy. They're going to look like somebody that is in shock, and they'll have a low blood pressure to go along with it. What happens here? This is usually the kind of end result of a long-standing CHF history. As your ventricle initially starts to get more work on it because you're hypertensive or for whatever reason, it gets kind of big and fat, just like if you exercised your bicep enough. It gets big and it gets hypertrophied and it gets kind of stiff, but it's big and it's trying to push more out. This is the way I think of it anyway. At some point, though, it's going to stop getting bigger and start just kind of expanding out. The ventricle cavity itself, instead of being smaller, is going to get dilated and just start stretching, sort of like an old balloon that you've blown up, 30 or 40 times. It just doesn't have the springiness that it used to. As it starts to dilate out, it's going to be less effective at pumping blood. And you can kind of get a picture here from the right side, which is a normal heart, pretty thick left ventricle cavity, a fairly thin right side. On this side, you've got a fairly big cavity here. That's not helpful, though, because you get this real thin-walled myocardium that's not able to really effectively pump. So instead of a nice, robust, healthy heart here, you have this dilated, stretched-out balloon thing that eventually is going to back up onto the right side and cause it to have problems as well. As you start to lose the ability to pump blood, your tissues need more oxygen and more substrate than you're able to provide with what you've got, and so they start to get hypoperfused. And what do you call that? That's shock. Shock is tissue hypoperfusion. In this case, it is pump failure, and it is hard to get that fixed without a new heart. Once you get to that point, we can do some stuff. We can try to flog the heart to make it pump forward enough, but at that point, we're getting into really bad problems here. This is really hard to treat. How do we treat it, though? Again, as I kind of mentioned, we're going to try to raise the blood pressure to not shock, and we're going to try to stimulate the heart as best we can to produce more forward flow. Go back to our diagram here for just a second. You got that big dilated left ventricle that's not able to pump very well, and so it's just not able to get blood out into the periphery. Looks something like that. You can imagine that trying to raise blood pressure on this guy in the way that we normally do, which is with vasopressors, norepinephrine or something like that. You got this dilated heart that's really just kind of sitting there twitching to start with, that's not pumping very effectively. If you increase the pressure that it has to pump against by giving them vasopressors, you can imagine that it's not going to help very much, because while you may get a higher blood pressure, the heart's still not going to be able to move blood out of there, because now it's that much harder and it couldn't do it in the first place. If you keep trying to increase the afterload, if you keep trying to increase the load on this thing, even if you think you're trying to do a good job by perfusing the other organs, eventually it's just going to fall apart, and the whole thing is going to collapse, and the patient will die. So the typical ways that we think about raising blood pressure may not work super effectively in this patient because they have a different physiology. We do want to try to raise the blood pressure to not shock, because that helps your other organs, but we want to do that while we're trying to increase forward flow. How do you do that? Well, we're going to think about a combination of use of IV fluid judiciously, because some of these folks will be actually overdiuresed, or they will have not enough fluid circulating around their body itself, and they may benefit from a little bit of IV fluid. We're not talking about bolus of 30 mLs per kilogram and get like 3 liters in this person before they get to the hospital. We're talking about if we give them a bolus of 250, do they get better? Okay, blood pressure is a little bit better. Let's give them another 250 and make sure that they're not becoming dyspneic or have significant periphery or pulmonary edema, and see if their blood pressure goes up. Now, if their blood pressure doesn't go up after that next 250, we don't keep giving it, but we can give judicious small boluses of IV fluid until we stop getting a good effect, and that's your fluid challenge essentially. The other thing we're going to do is add drugs into the mix. So before we were giving medicines to decrease peripheral vascular resistance and decrease blood pressure, now we're going to give some drugs that may actually cause some vasoconstriction, such as norepinephrine and epinephrine, and then inotropes themselves, such as dobutamine and milrinone. Now, we talked a little bit about inotropes and pressors before. If you remember what we're typically used to giving, it mostly causes vasoconstriction without a lot of actual, flog to the heart itself, make the heart squeeze faster or squeeze better. In this case, we're going to reach for the ones that cause more heart squeeze and less vasoconstriction. The two that we really like for that are dobutamine and milrinone. If we have to, with those though, they tend to actually drop your blood pressure a little bit. So when you throw some dobutamine on somebody, it may actually cause a little bit more vasodilation, which causes more hypoperfusion because your organs can't auto-regulate anymore, especially your kidneys and your brain. So as we're getting the heart to beat faster with some dobutamine or milrinone, then or for that matter, low-dose epinephrine, what we might need to add on too is a little bit of vasoconstrictor. So in this case, we give you just a little bit more vascular tone while we are trying to make the pump go a little bit better. So something like a small dose of Levophed or epinephrine will give you, low-dose epinephrine will give you some inotropy as well as a little bit of vasoconstriction. Both of those are reasonable things to give for somebody in cardiogenic shock. Now, many of our EMS services don't have dobutamine or milrinone. Some air services may have it available. Some critical care transport services may have dobutamine out there. If you don't have dobutamine, then probably the best thing to reach for is a little bit of push-dose epinephrine. And don't go crazy with this one. This is not the guy to try, slamming in 100 mics or something like that. Go with 5 or 10 mics to start with and see what happens. And a lot of times that's enough to get the person a little bit better. By the way, how do you know that this person gets better? Well, yes, their blood pressure comes up a little bit, but they should pink up at that point. They should stop being cold and clammy and hypoperfused and mottled. That's the real way you're going to know. Their lactate should, if you're following lactate or whatever, their lactate should start to go down eventually. We want to get these guys, not only do we want to artificially increase their blood pressure just to make ourselves feel better, but we want to increase the forward flow and actually provide some tissue perfusion. Let's talk now about the fourth category, which is any of those blood pressure categories plus ACS. So he's got an anterior STEMI, he's got a widowmaker. These, luckily, are not all that complicated to take care of because you treat them like above. If they're really hypertensive, you can give them some nitroglycerin. If they're just normotensive, you give them just nitro. You add CPAP to both the above. If they're hypotensive, then we might try to give them a little bit of epinephrine and try to get their blood pressure up and get some more perfusion. We're going to give them an aspirin is the big addition here from an EMS, and then we are going to take them someplace that has the ability to do an intervention. So if you see somebody that is likely a CHF exacerbation, but also they have significant ST elevation, or you're transporting somebody from place to place that has an elevated troponin, a climbing troponin, even though they're a CHF exacerbation, this is probably somebody that needs to go someplace with a cath lab. So if you see it in the field, we're going to give them an aspirin, take them to someplace with a cath lab, and overall treat them like any of the other phenotypes that we just saw before. So important to add this in, that we do need to get them someplace that can do an intervention, but for the most part, we're going to treat them like we did above. This brings us to our last section. Part 5 of this is going to be the guys with right ventricular failure. Again, everything I've said before is primarily based on LV failure, but at some point you can get some right-sided failure. What's the most common cause of right-sided failure? Well, it's usually left-sided because you eventually back up into the left side of the heart. But there are some folks that have right-sided heart failure primarily, either because of an MI or because of a PE or because of pulmonary hypertension from their bad COPD or other things that can happen as well. The right side is a little bit different than the left, and here's the interesting thing about it. So the right side of the heart has a pretty thin wall to start with. There's and it's designed to kind of stretch a bit better than the left side does. It's a relatively low pressure system to start with. It doesn't have to have a lot of mass, and it is able to expand out as blood backs up into it. So that's kind of good because, you tend to get less like, oh my gosh, this happened right away. However, as you start to distend, as you start to stretch out that right ventricle, it starts to actually push on the left side. And as the right side gets bigger and bigger and bigger and pushes on the left side gets smaller and smaller and smaller. When the left side, the left ventricle cavity gets squished, then it makes it harder for blood to go from the lungs back into the LV, which backs up through the pulmonary circulation and back into the right ventricle, which makes it more distended, which pushes on the left side more, and so it turns into this vicious cycle where once you start getting some RV dysfunction and it starts to balloon out, you start to squish the left side and the whole thing goes south in that point. What might these guys look like? They may present with dyspnea or pulmonary edema, but in this case, they're going to primarily back up onto the periphery before they back up into the lungs. Eventually, theoretically, you could go all the way through the left side and back up into the lungs themselves, or maybe they're dyspneic because they've got a big PE or something like that. But these folks will oftentimes have a lot of peripheral edema. they may actually be a little bit volume down because we've tried to diurese them so much, but their blood on the venous side just can't go anyplace, and so it doesn't do a whole lot of good to diurese them. Now, the one problem with these folks with that, you think, oh, well, it's not that big a deal. They just get some peripheral swelling. Well, the problem is if you can't effectively get blood out of the right side of your heart and through your lungs, you can't pump it out the left side, and so you don't get forward flow. So these people, again, may be in frank shock with just some peripheral edema, but not a lot of pulmonary edema. And as I kind of mentioned before, here's the big distended right side of the heart. Normally this would be the big cavity here, but the right side of the heart has pushed the septum over and squished this left ventricle cavity down to the point that it really can't accept much blood anymore. So in this case, we are going to take some of the same concepts that we used before and try to treat this right-sided heart failure. This is kind of tricky, and this is not something that any of us really want to get into. But the way that we do that is to try to treat the pump failure on the right side. We try to decrease preload if possible, although maybe not that important right at our time when EMS is seeing them. And then we try to decrease afterload. So how are we doing that? So we're going to treat the right-sided pump failure to start with, and mostly we're going to do that by, again, raising their blood pressure a little bit with some peripheral vasopressors, and by using inotropes to try to flog the right ventricle into working a little bit better. This is pretty much the same as previous. In these folks, epinephrine is probably one of our better choices. So little bits of push dose epinephrine or a low dose epinephrine infusion is not a bad choice. If you have dobutamine available, you might think about using it as well, just to give the heart a little bit of more flogging. But keep in mind that when you give somebody dobutamine or milrinone, one of the pure inotropes or more pure inotropes, you tend to drop their blood pressure, and if they're in shock, that's a problem for them. So you may need to add a little bit of peripheral vasoconstrictor as well. And again, epi is probably about the best one for that, specifically because it causes probably the least amount of pulmonary vascular resistance increase. And so you're able to flow through the pulmonary vasculature a little bit better. We might think about giving these folks some diuretics, but again, they may be over-diuresed to start with. There may not be that much volume circulating around inside them because they've had increasing dose of Lasix and increasing dose of Lasix and increasing dose of Lasix because they've gotten so backed up. So diuretics probably not all that helpful in these guys especially, and I would just shy away from it in EMS, as I've kind of mentioned about 10 or 12 times now. How about working on RV afterload? We treat the same way as we might with stuff on the left side, but how do you get the pulmonary vasculature to kind of open up? We know how to do the peripheral vasculature. What do we do about the pulmonary stuff? Well, in this case, what you're going to try to do is do all the stuff that you would normally do in terms of best pulmonary kind of practices, best breathing sort of practices in EMS. Because when you increase the amount of oxygenating area in the lungs, then you increase blood flow through the lungs themselves. You decrease shunt. As you decrease shunt, you decrease the pulmonary vascular resistance. So what do we do here? We're going to give these folks oxygen. And this may be somebody to give some supplemental oxygen to, even if they don't need it per se, like they're 94, I'd still put oxygen on these folks. And then this may be somebody that benefits from recruiting extra lung sections through PEEP or BiPAP, because that will help to open up new lung segments, keep them open, and improve blood flow and decrease pulmonary vascular resistance through that area. We want to provide adequate ventilations, but a relatively low tidal volume. So again, we want to keep the lungs open as much as we can with decent amounts of PEEP or with use of CPAP or BiPAP. But then when if we're having to ventilate the person like on a mechanical vent, we want to provide enough, but not so much tidal volume that you distend the lungs each time, because every time you increase intrathoracic pressure, you make it a little bit harder for the for the right side of the heart to pump blood through to reach the left side of the heart. So adequate ventilation with good amounts of PEEP or with CPAP or BiPAP, some positive pressure, but a relatively low tidal volume. 6 mLs per kilo is just fine for these folks. All right, that was a little bit convoluted at the end, but let's sum this up real quick. So, again, we can divide folks down into about 4 or 5 or maybe 6 different phenotypes, depending on how specifically you want to break it down. For most of the folks we see, they're either going to be hypertensive, normotensive, or potentially less commonly in cardiogenic shock. If they are hypertensive, we're going to give them a bunch of nitroglycerin. We're going to put them on BiPAP and get their blood pressure down aggressively. And with that, we can usually get them better pretty quickly. The folks that are grossly fluid overloaded, that have been getting dyspneic over the course of 2 weeks or so, but have a normal-ish blood pressure, we're again going to put on CPAP or BiPAP, positive pressure ventilation. Give them nitroglycerin, but not 6 tabs at a time, maybe just 1 tab at a time, and drive their blood pressure down to 100 or until they get better. And these folks might be the only folks that diuretics may be helpful for, but again, kind of complicated. I would advise that we probably don't do it in the field, at least till we get some more information. And then the cardiogenic shock folks, if necessary, we can try putting on positive pressure. Most of these folks won't be terribly dyspneic, though. They're going to be more of a hypoperfusion state. So their lactate will be up and they'll look cold, cool, mottled skin, that sort of stuff. These are folks to put on some kind of inotrope. You can do dopamine, you can do milrinone. If you have dobutamine, you can do that. That's about my favorite. A little skosh of dobutamine, a little skosh of norepinephrine to treat their blood pressure, and folks get better. And you can give these folks a little bit of fluid, not 1,000 mLs at a time. Give them 250 at a time. Reassess. Is the blood pressure better? Do they have fluid in their lungs? If they are getting a little bit better, you can give them a little bit more fluid. You don't have to not give them fluid in this case. You just have to be careful with it. If any of these folks have evidence of acute coronary syndrome, new EKG changes that look ischemic, or an outright STEMI, we need to give them an aspirin, and we need to take them someplace that has the ability to do cardiac intervention, i.e. cath lab, with them. And go ahead and call this. Even if they're in distress, I would go ahead and call this as a STEMI alert, or whatever your STEMI appropriate STEMI designation is, because even if they're in pretty significant distress, these are folks that we still think probably need an intervention and are going to need it relatively quickly. And then right heart failure is a little bit different. In this case, again, they're going to have a lot of peripheral edema. They may be in frank shock without a lot of pulmonary edema. These folks, we're going to decrease their afterload through the lungs by providing lots of oxygen, adequate non-invasive positive pressure ventilation, or PEEP if they are intubated, and relatively low tidal volume ventilation, but ventilation adequate to try to normalize their blood gases at least a little bit. We might give them a little bit of diuretics. Again, not necessarily something that I would recommend in the pre-hospital setting, because these folks are super complicated. And then in order to help their pump work a little bit better, work that dilated RV a little bit better, we are going to consider probably not giving fluids. Take that completely off there. Forget I said it, although you might maybe do it, but probably not. Consider inotropes and a little bit of peripheral vasoconstriction. And again, in this case, what most of us from an EMS setting are probably going to be familiar with is a little bit of push dose epinephrine every couple of minutes. And you'll find these folks, again, what's in this case the way that we know that they're getting a little bit better. Their blood pressure goes up, but they pink up a little bit more. And these folks can be super hard with right-sided heart failure, super hard to take care of, super confusing. A couple other little pearls. Nitroglycerin is safe, and you should use a lot of it in your acute decompensated heart failure patients. CPAP is safe, and you should use a lot of it. Remember that if you increase pressure, or if you increase FiO2, you may actually decrease the amount of flow, the amount of actual gas that the patient gets. So if you made a big change and all of a sudden you thought this was going to be more helpful for the person because you have a low flow CPAP system, just go back on that change and the patient will often get better. Again, how do you know the patient with heart failure is improving? How do we know that we're doing the right stuff? Patient feels better. It's mostly a symptomatic thing. There's not a lot of other stuff that really has been shown to, evidence-based medicine that improves heart failure. It's how the patient feels. So if you've got a setting that makes the patient feel better, use that for now, as long as you're not clearly killing them. Here's our email. Here's our website. Check out emsgranderons.org. You're probably there right now. And if you are, thanks for hanging out with us. But let us know if you have any questions, and we'll catch you later.